The following advisory guide is intended for medical professionals and risk mitigators. noTRACH advises that the following guidelines should be used in determining when a tracheostomy is clinically required, and precautions that should be taken prior to being performed. Your organization may have additional requirements for clinical justification and legal risk mitigation. Having performed a tracheostomy, or about to perform one, you may be concerned that a claim may be made against you, or you may already have had a claim made against you. Depending on your location, the consequences can lead from a claim of compensation from a patient or his or her family for medical negligence to a criminal prosecution. Key points. Negligence arising from medical acts may result in a civil action by the injured party, claimant, or a criminal prosecution by the state. Medical negligence is proved if all components of the three-part test are established on the balance of probabilities in a civil suit, or beyond reasonable doubt in criminal prosecution. The three-part test establishes that the doctor owed a duty of care to the patient. The duty of care was breached, and as a direct result of the breach, the patient suffered harm. Successful civil actions result in monetary compensation to the injured party, or dependents which may be paid by the employing organization or the doctor's defense organization. Successful criminal prosecutions may result in a custodial sentence for the doctor, and additionally, the possibility of being struck off, no longer permitted to practice medicine. It is essential to have proper record keeping and evidence that the tracheostomy was performed as a last resort and was absolutely clinically necessary. If it is established that a tracheostomy was not necessary, a claim by a health insurance provider may also follow for recovery of the costs of the procedure and subsequent expense. A claim for negligence involving a tracheostomy may be the result of the procedure being performed when it was not necessary, insufficient explanation to the patient of potential complications and quality of life implications to have given informed consent, death and complications and side effects that could have been avoided, negligence of care post-procedure, not informing the patient or trying all other available alternative forms of respiratory support. The decision to perform a tracheostomy should clearly meet the following test: that its clinical requirement is beyond doubt or was the result of an emergency event, and all possibilities of alternative available forms of non-invasive ventilation have failed or were not appropriate, and the patient is fully aware of the life-altering implications involved and the potential complications that may result. Failure to meet this test will clearly establish that negligence has occurred. Clinical requirement. The clinical requirement for a tracheostomy is easily established, but limited. In order to demonstrate clinical necessity, the following must be established: the lack of a viable airway and/or failure of both available forms of non-invasive ventilation, for example, mask-based and biphasic cuirass ventilation, or circumstance which would preclude either form of non-invasive ventilation from being attempted. This can include contraindications for use of either method of non-invasive ventilation. For example, lack of patent or viable airway, bodily burns in the case of biphasic cuirass ventilation, facial trauma in the case of mask-based ventilation. Where negligence is criminal. If negligence occurs as a result of carelessness, then where the carelessness has been so severe that it is judged to be gross, the doctor may be subject to a charge of criminal negligence. Although the requirement to prove criminal negligence is a much higher one, for example, beyond reasonable doubt, the sanctions are considerably greater and may include a custodial prison sentence for any doctor found guilty of such an offense, in addition to being prohibited from practicing in the future. Informed consent. In order to clearly prove that informed consent has been given, the following tests should be met. The patient has been made aware of the complications and their prevalence that can follow a tracheostomy, for example, risk of infections, bleeding, damage to vocal cords, etc. The aftercare requirements following the procedure. Quality of life impact issues, for example, difficulties in talking, eating, etc. That both alternative forms of non-invasive ventilation are available and have either failed or are contraindicated or have been specifically declined. Alternative forms of ventilation. Currently, two mainstream forms of non-invasive ventilation are available: NIPPV, non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation is very well proven and is often used as an alternative to invasive ventilation. NIPPV may be used with either a mask or mouthpiece as an interface. There is a significant body of clinical evidence that illustrates its use as a safe, effective alternative to invasive ventilation. Available worldwide. BCV, biphasic cuirass ventilation. Biphasic cuirass ventilation is also very well proven and used as an alternative form of non-invasive ventilation. BCV is used with a cuirass, a semi-rigid plastic shell, as an interface. Biphasic cuirass ventilation also has a significant body of evidence that illustrates its use as a safe and effective alternative to invasive ventilation. Available worldwide. Both forms of ventilation have many hundreds of clinical publications supporting their use and are used by thousands around the world. It is very well proven that where one method has failed, the other has proved effective. Discussion. For many medical professionals, a tracheostomy procedure appears to be a rather simple, quick fix to assist patients in respiratory distress. It can indeed greatly simplify care of a patient requiring ventilation. In some cases, it has become a source of revenue for institutions. It is not uncommon for fees for this procedure and immediate respective care to exceed $250,000. This in itself raises alarm for many. There is no question that at times, this procedure is not only necessary, but life-saving. However, what has become apparent is that tracheostomies have become too readily performed, despite their numerous and very serious complications, which include risk of death and need not have been performed. In the United States alone, upwards of 150,000 tracheostomies are performed annually. This is a conservative estimate, and only of the adult population. It is obvious a great many patients have been significantly harmed, and many may have died. Where the tests for clinical necessity and informed consent have not been met, claims for negligence will inevitably follow, and harm easily established. For more information, visit www.notrach.com.